DDN. Today in our regular medical segment, we are bringing you a talk with Dr. Minoo Patel. Welcome to our DDN program, Doctor.
Hello.
Dr. Minoo Patel is a leading orthopedic surgeon and he is practicing at Epworth and Cabrini Hospital, and he is the senior lecturer in Monash University, and he is the chairman of Australian Orthopedic Association Research Foundation. He has special interest in shoulder and elbow surgery and deformity correction and limb lengthening. He is a strong proponent of evidence-based medicine. Today, we will discuss the common medical condition arthritis of the joints. Thank you for being with us, Doctor.
Thank you for having me.
We have some questions, common questions for our viewers.
Sure.
Please explain what is arthritis.
Arthritis is a condition that affects the joints, and the literal meaning is inflammation of the joints. There are essentially two wide sort of subclasses of arthritis. One is what is called as an inflammatory joint disease, or what used to be called rheumatoid arthritis, and the other one is the common variety of osteoarthritis, or what is appropriately called degenerative joint disease. Inflammatory arthritis is an autoimmune condition, generally starts early, affects young people, and the treatment is mainly medical. So much so that over the past 10 years, the advances in medical management of rheumatoid arthritis has meant that the surgical intervention rates have dramatically gone down. The more common variety, what people would sort of experience, is what we call osteoarthritis, which actually is not exactly a very correct term. The more appropriate term would be degenerative joint disease. And what happens in degenerative joint disease is that the ends of the bones, which have what we call cartilage, it wears off, and you then get very poor shock absorption, and that causes pain. And eventually, when all of the cartilage is worn out on both sides of the joint, you can get what is called as bone rubbing against bone, so that you get pain, you can feel the creaking and grating of the joints, and then you need to have some intervention.
Okay. Then what are the predisposing factors of this condition, arthritis, please?
Well, some of the predisposing factors are known, such as overactivity or any injury or trauma that you might have. Sportsmen, because they overuse their joints, may be prone to getting osteoarthritis. Also, people who have certain deformities in the limbs can get different types of arthritis. But at the end of the day, it's just plain wear and tear. And unfortunately, we still don't know why certain joints will get arthritic and certain joints won't.
Is it common in Indian community, Doctor?
Yes, unfortunately it is. There are two types of arthritis that are common. They are always common in the load-bearing joints. So there's the hip arthritis and the knee arthritis. And amongst the Asian community, hip arthritis is quite rare. It is almost essentially a European disease. It's because of the way in which the hip joint is made. On the other hand, knee osteoarthritis, especially the wearing up the inner compartment of the knee, is much more common amongst the South Asian people, because we tend to be more bow-legged, and then other habits such as kneeling, squatting, etc., they tend to wear out the joint between the kneecap and the femur bone, and therefore osteoarthritis of the knee is a relatively common condition amongst the Asian population.
Interesting. Then how do you prevent it, Doctor?
There are no specific preventative measures that one can take. I mean, one does have to live an active lifestyle. As we are living longer and living very active lifestyles, the joints are going to wear out. What we're not doing, unfortunately, is keeping the muscles that control the joint strong. So one of the simplest preventative measure one could take would be to keep the muscle strong. So for example, in the knee, you want to keep the quadriceps, which is in the front of your knee, and the hamstrings at the back of your knee strong. You can do that by regular exercise, but what is important is not just walking or riding a bicycle, but resistance training. So you have to do resistance exercises with some light weights, and especially in the knee, this has been shown that even if you have early arthritic symptoms, those symptoms can be kept at bay without requiring further intervention if you keep your muscles strong. Similarly, in the shoulder, if you keep your rotator cuff muscle strong, you can also avoid any further trouble. But by and large, stay active, keep the weight down. I mean, that's the other problem as we go heavier and heavier. And as we grow older, it becomes more and more difficult to keep the weight under control. And certainly the knee and the hip are very prone to weight-related arthritis, which is degenerative joint disease.
So that's one of the treatment, rather, keeping the weight under. And what are the other treatments, doctor?
Well, I mean, certainly weight loss will help with hip and knee arthritis.
Yes.
There was a very good study in Boston which showed that if you exercise your knees, the people who exercise the knees, even with arthritis, are less likely to require, joint replacement, which brings us to the treatment. So in terms of treatment, you've got the non-operative treatment and you've got the operative treatment, and we'll use the knee kind of as the base joint on which we can sort of reference all our recommendations. So treatment number one, anti-inflammatories, other painkiller medications in short, sharp bursts. Maybe occasionally a steroid injection, though that is not terribly good for the cartilage. And exercising, keeping the quadriceps and hamstrings strong, and with or without the help of a physiotherapist. So these are what we call as non-interventionist or non-operative methods. Sometimes operative intervention is necessary. One of the simplest operative interventions, which was very popular and still is popular, is knee arthroscopy. There's been a bit of controversy recently with a couple of papers now showing that in arthritis, so we're not talking about the young sportsman who does a meniscus tear or a cruciate ligament tear requiring a reconstruction, but in arthritis, when you compare arthroscopic surgery versus placebo or sham surgery, there's not much of a difference. But that said, every intervention has to be tailor-made to the patient, so it's important to discuss with your surgeon or with your doctor whether an arthroscopy may just buy you some extra years and take away the acute source of pain, such as a meniscus tear, and allow you to do the exercises. Because here's a catch-22, your knee is sore and your doctor is telling you to do exercises. So it's important to get rid of the pain first and then mobilize the knee. But at the end of the day, eventually, when the joint is completely worn out, what we call bone-on-bone arthritis, and if the pain becomes a hindrance to lifestyle, it takes the enjoyment out of life, or you have a deformity, so your knee can't be fully straightened, or you've got a severe bow-legged deformity, then a joint replacement will be the only option. And joint replacement has been around for at least 25 years now, with some very reliable, very reproducible results. Now here's an example. Sorry.
Yes, sir.
So when the cartilage in the knee joint is worn out, this is what we do. We put this metal bit on the femur bone, this bit on the tibia bone, and a plastic in between, and then you can move the joint nicely and smoothly.
Right.
In Australia, we're very lucky. We have a very well-coordinated system. We have a national joint replacement registry, and on an average, you can expect one of these joints to last you between 12 and 15 years' time.
That's pretty good. That's pretty good. So, doctor, what about the? I see that you are doing some fractures and things like that. So, what about the bone density and what one should calcium intake and those kind of things? People, wonder whether our bones are strong or not. and they take so many medication, calcium plus and this and that. So what do you think about those things?
Well, I mean, this comes to the point of general bone health.
Yeah.
Unfortunately, the scary thing is that what is called as peak bone mass is reached at age 20 to 25. And after that, it's downhill all the way. And what happens is that when we get busy in our lifestyles, we think that we're tired at the end of the day, and that is good enough. But as far as the bones are concerned, that is not good enough. So what is required is load-bearing exercise. You have to bear load, walking, running, etc. Even cycling has been shown not to be beneficial to increasing the bone mass. You literally have to load your joints and load your bones. So load-bearing exercise is good. Also, a healthy diet. Now that becomes a problem with certain classes of vegetarians or vegans, where you may not get adequate amount of calcium or vitamin D, and you may need additional intake. Also, people with darker skin require greater exposure to the sun for a much longer period of time to generate the same amount of vitamin D that a fair-skinned person might need. But vitamin D and calcium supplements are relatively safe, and in particular as you grow older you may need those. Another special category is women, because women undergo menopause, and after menopause the estrogen and progesterone hormones are lower, and therefore they tend to lose bone mass much rapidly than say males would. So again, consult your doctors. You may need to take calcium and vitamin D supplements. If your bone density is really poor, then there are a separate class of medications called bisphosphonates, which again can be taken again with the guidance of a general practitioner or an endocrinologist. You mentioned other supplements, and I want to add here that there's a fad amongst the community to look for a quick fix, and that includes things like chondroitin sulfate, glucosamine, fish oil and krill oil. Unfortunately, there's a dictum in medicine: if it's too good to be true, it is. So the American Academy of Orthopedic Surgeons came up with a position statement categorically stating that glucosamine, chondroitin sulfate, fish oil, krill oil have no benefit at all in preventing or treating joint diseases. There's also another unfortunate fad that is coming up, is the special injections that people are offering in the knee, like PRP, which is platelet-rich plasma, or even supposedly stem cells, each one of which can set you back thousands of dollars. And unfortunately, the problem is that they don't work. The evidence is very sketchy, and again, the Academy of Orthopedic Surgeons in the US has said that at this stage, apart from research studies, PRP and stem cell injections in the joint should not be used as a routine. There was another little fad that came about, which is called viscosupplementation, which was hyaluronic acid injections. Again, each one costing about $300-400, and unfortunately it came with a big expectation, but the evidence does not show that it works. So it's back to the drawing board and doing the hard yards, i.e. doing your exercises, keeping your joints strong, and trying to avoid getting the joints worn out in the first place.
That's pretty informative session, Doctor.
Thank you.
And for our viewers, for more information, what do you suggest? Is there anywhere they can go and find out some more information? Please?
Well, you could certainly talk to your GP. I mean, your family doctor should be your main portal of information. But in this day and age, with Dr. Google around, a lot of people go to the internet to get their information. It's very important to get non-biased information. And the two best sources that I can recommend are the reliable websites that are run by the Australian Orthopedic Association, which is aoa.org.au, and the American Academy of Orthopedic Surgeons, which is aaos.org. They have position papers, especially the American Academy. You can actually go and search for specific conditions, and it can tell you what the evidence-based recommendation for the treatment are. And also, both these websites explain things in lay people's language. So rather than medical terminology which scares off a lot of people, these websites give you good explanations in common English with good pictures, and also something that is evidence-based. So nothing that is not proven is recommended on those websites.
That's pretty good. Thank you, doctor.
Thank you.
And
I'll show you
This
some
is-
examples.
yeah, and that's one thing. We'll finish off this one.
Yeah.
Thank you for being with us, doctor, today. It was a very insightful information for our viewers, and thank you once again.
Thank you for having me.